So I'll hand back over to you, Chris.
Yeah, and we'll hopefully touch on some of that as well. So, with regards to, the we talk about prevention, and then we'll probably go all the way back to preventing diabetes in essence. But with regards to when someone has got diabetes, is the vigilance that if something happens to the foot, trying to get to the triad and diagnosing the problems and stopping it at source. So when anyone presents with any foot lesion or any foot problem, be the clinician or the patient should know that something needs to be done quickly to try and stop this in its tracks. The same way as we touched upon about maybe breast exam for people with possible breast cancer, or even people with query heart attacks, having an ECG or going to the accident and emergency and so on. So in regards to preventing the diabetic foot disease from worsening, these are what I'm going to go tackle: the vascular side, the neuropathy side, and the infection side, because the need for urgent action is what will prevent the amputation. And shows that yes, if you prevent the amputation, if you prevent the infections from getting worse, that's how we're going to save lives and save limbs. So that's when I'm talking about some of the caveats, that it is very, very difficult or the presentation for ischemia in patients with diabetes is very different from patients without diabetes. And it's also slightly more difficult in patients with a dark skin. So when people have got poor blood flow to the feet, normally the first thing that people will get is pain. Or we might hear about people having claudication, or when they walk, they start getting pain in their calves. And that's sometimes the early signs of poor blood flow in the foot. But you need to recognize that people with diabetes have got neuropathy. So they've got decreased sensation. So they are not going to get those warning signs early enough to get them to know that, okay, there's poor blood flow in my foot, as people who do not have diabetes. Again, people with diabetes, as I show you, their foot can change shape. So they have different pressure points, which can cause an area to have poor blood supply. You probably might have heard about people with bed sores or heel ulcers because they've been lying in the same place for quite a while and they get pressure areas that develop ulceration. The same thing happens with the foot, that when you've got neuropathy, people put more pressure on their foot and then they can develop area of ulceration because of the pressure. Again, when the neuropathy is there, what we call autoregulation. So in all of us, when we are hot or cold, our blood vessels will constrict and dilate to accommodate. But when you've got neuropathy, you lose all of that as well. So the skin changes can be defective as well in terms of using it. Again, we all taught to do capillary refill, which you can do it quite easily sometimes in people with light skin. But if you do it in someone with very, very dark skin, it's very, very difficult to tell that the capillary refill is reduced. Again, some of the early signs of poor blood supply. Again, with regards to the metabolic effect or increased risk of infection. So when you've got an infection at a site, that area needs more blood supply to help fight the infection. But when people have got ischemia, that blood will not get there to help fight that infection there. And I've already talked about the claudication being a very, very, very late response, because the claudication is really when you get pain in the calves, whereas this problem is happening in the foot itself. So the people get the rest pain much, much, much late on. Again, I'm sure we apologize for the pictures in the beginning. So on the left hand side, you can see someone with a dark skin, and you can tell as you lose blood supply, or perhaps if I move to this picture here on the right side, someone with a light skin or a white Caucasian skin, you can easily tell where the tissue is dying or where there isn't enough blood supply going to that area. Or even in this patient, it has become very, very obvious that the blood supply is poor, because people can tell the changes very, very quickly and much more obvious compared to the other foot. Whereas in people with dark skin, this foot is very, very, very ischemic. But it's very, very difficult to tell because sometimes the darkness of the toes can be very subtle compared to the patient's normal skin color. And the ischemia could be exactly the same. But sometimes clinicians might rush more and respond much more quickly when the skin color makes it very, very obvious of the dying tissue. Whereas in people with dark skin, it's much more difficult to detect. Even I should have maybe blown this picture up, but you can tell the difference in these three toes, the colors of these three toes compared to that has gone a bit more dusky. And these are all some of the subtle changes that can be missed in people with dark skin, because these patients may not all, they will not be having pain. They'll all be pain free. And it's from the clinicians examining the foot to say, okay, I think this foot is ischemic. Or from even for the patient realizing that, okay, the skin has changed color. And you can tell the changes here is much obvious to see compared to the changes here. So that's why it is much more difficult to diagnose some of this ischemia in people with dark skin. Sorry, Joan.
No problem, Chris. So much information, because it's about knowledge, but it's not just knowledge for the person living with diabetes, it's knowledge for the healthcare professional as well. So I'm so grateful to you for highlighting this and raising awareness and knowledge of healthcare professionals that they need to have this information and know how to diagnose that ischemia in darker skins, in black skins, in the same way that they would do in a white or Caucasian skin. So I'm just really grateful to you, Chris, for highlighting this and raising the awareness.
So again, another aspect, this is a data from an Italian team. They looked at the blood vessels of nearly 2,500 patients. So these patients who have had angioplasty, so they've had a dye introduced into their foot to see where the blockages are in their leg, so the poor blood supply. And here is sort of a series of the anatomy of how the legs sort of look like. So this is sort of the femoral, or in the thigh, around the knee, and basically when you go below the ankle. And as we all get older, there is more blockages lower down in the foot. In the male gender, this was how it is sort of spread out, that you get more in the groin or in the thigh area, and again in the foot. Diabetes, we know, causes more blockage, more distal to the foot. So this is the change. The blockages were more in the foot. When people have got hypertension, it was affecting all the blood vessels in the foot. When people who have got high cholesterol, they notice that they have got more blockages, more proximal, or more in the sort of thigh area, the same as the people who smoke. So that's why traditionally, people with high cholesterol, people who smoke, their blockages are in the thigh. So when they walk, they get pain in the calves here. But in people with diabetes, because the blockages are much lower down, they do not get the same sort of symptoms when they walk, or it's not as obvious because the blockages are much more in the foot. But in people of Africa and developing countries, what we are having is more and more people smoking, people having other comorbidities like hypertension that is not treated, and high cholesterol. Most of our diet, I'm sure you have other webinars and so on about diet. So all of these are impacting on people of Black and ethnic minorities, that they've got all these other complications that are causing the blood vessels to be much more occluded. And hence the pathology is going to be much more severe and aggressive in terms of the blood flow. Now moving on to the infection side of things. So that was the blood flow. With infection, there are guidelines out there. For example, there are guidelines from the International Working Group on the Diabetic Foot, or the Infectious Disease Society of America. So these all give the clinicians guidelines as to how to detect infection in people. So you can grade infection in the diabetic foot from, let's say, 1 to 4 in terms of the severity. So when you say, okay, it's non-infected, then there's no signs or local signs of infection. And how clinicians will diagnose the infection is the erythema, or the redness around the wound, or whether there's swelling. But the main thing I'll dwell on is about the redness around the roof, or the erythema. Straight away, you can tell that it's very, very difficult to tell the redness when the skin is dark. But these are international guidelines. And I'm not saying they are geared towards people with lighter skin, but it is much more easier to pick up the erythema in people with a light skin, which I'll show some pictures later. So you have to have a high level of suspicion to pick up infection early in people with dark skin. And again, we talk about local tenderness or local warmth as early signs of infection. Again, from the last few minutes, you have told that there will be no local tenderness because they've got neuropathy. So they will not complain of pain. And in terms of increased warmth, again, we're talking about the blood flow. If the blood flow is poor, you're not going to get that warmth because there's no blood going there to make it warm. So these are all subtle reasons why infection will be picked up late. So you go to mild infection, then you expect that erythema to be more than 2 centimeters around the wound. But we know that we don't get that in people with diabetes. Because of the neuropathy, I talked about the vasodilation, about the blood vessels dilating and constricting. And you need the nerves to do that. So when you've got infection, you get vasodilatation and more blood goes to that area. But you won't get that in people with diabetes. And more worse so, in people with dark skin, you will not see that redness of the skin. So this is a picture of a lady. Again, you could tell how she's painted her nails nicely. There was supposed to have been an x-ray on here, but if you were to see the x-ray of this toe is completely necrotic on the inside, and she had to have the toe amputated. But you could tell that, yes, she's painted her nails, completely oblivious about how severe the infection in that foot is. And if you look at the sole, the part of the foot, again, this will not be classified as erythema. But that toe is completely devitalized. There's no blood in that toe there. That's why it is white. But a clinician or someone will be looking for, okay, I'm looking for erythema, I'm looking for redness, I'm looking for warmth. But this toe is completely dead. And it's completely devitalized. There's no blood in that foot. That's why it is looking that white. It should be looking like that color there. So again, clinicians and patients have to be extra vigilant when trying to diagnose infection. Sorry, Joan.
No problem, Chris. I'm sorry to interrupt you. I just wanted to highlight, because I think it's a really important aspect here. If we're trying to raise awareness, if we're trying to raise knowledge, a lot of people like to get their pedicure. This lady probably went for a pedicure. And the person who did the pedicure may not even have realized that this lady had diabetes, that they were living with diabetes. And that's one of the things I do want to highlight, that it is so important. If you are going for a pedicure, a manicure, please let that person who is doing your pedicure or your manicure know that you are living with diabetes. The reason being, it may be that some of the issues that arose now in this lady's foot might have occurred when she had that pedicure. If she did the pedicure herself, sometimes people don't realize that when they're doing certain things to their nails, the way they look after or try to treat their nails, they may do damage to themselves. Somebody who's doing a pedicure can do damage. I mean, so it's just to be safe, to be aware, and to have that knowledge. So some little nick with the instruments may have occurred when you're doing a pedicure yourself, or you go for a pedicure and you don't realize that it can then lead to these really awful consequences. And as we found out earlier, having an amputation of one toe is going to increase things like your mortality risk. And the other thing I would add is that the toe is just hugely swollen. So that may have been the thing that finally brought her to the clinic. But, look how swollen the toe is before action was taken. So we just all need to be so aware.